I was able to attend a ribbon cutting on Monday for the Stewart Community Hospital in Patrick County, Virginia. It was a reopening of one of my rural hospitals that had previously closed down back in 2017, and that's just really good news, and was very, very pleased to be there. All right, Ms. Van Meter, I have concerns particularly about routine tests that patients rely on every day. In your testimony, you mentioned one such test, a complete blood count test that regularly is furnished by these smaller labs. That is currently reimbursed under the clinical lab fee schedule at $7.77. However, you state that it is scheduled to be cut by 11% on January 31st, absent a change in the law. What does this mean for patient access to this test and others like it if we don't take action?
Thank you, Mr. Chairman, for the question. A CBC is a very commonly ordered test. It can tell us quite a lot about monitoring a patient's condition, diagnosing it, the health of their immune system. It can often be the first sign that there may be a blood cancer like a leukemia. And you're exactly right. The Medicare program currently reimburses $7.77 for this extraordinarily valuable test. That means the blood draw, the transportation to the laboratory, the medical laboratory professionals who assess that sample, run the test, and deliver the results to the patient and their clinicians. And that is done for $7.77. It's a perfectly illustrative test of the value of clinical laboratories. Now, that test is among the most common tests ordered, and common tests are subject to a disproportionate level of reductions under PAMA. Those cuts take place on January 31st. For smaller laboratories in rural or frontier communities, for example, that have more narrower menus that focus really on those essential common tests, we have significant concerns about them being able to weather these deep Medicare cuts, again, that are disproportionately hitting those common tests that Medicare beneficiaries rely on every day.
And let me see if and you correct me if I've got my translation wrong, but if you're in a big city and you're doing 1,000 of those tests a day, you might be able to justify the 777, maybe a little bit of a cut. But if you're in a rural area where you're doing 5 of those tests a day, there's no way you can possibly manage it for that amount of money. And so you've either got to decide whether you close up shop or whether you just stop doing that test. Is that what I'm hearing?
Well, I think the impact could be profound for smaller laboratories in particular, but I must say even larger laboratories, whether they be in urban areas or small communities, there can be large laboratories in small communities, it is extraordinarily difficult to have the professional laboratorian staff and the infrastructure, these labs run 24/7, to be able to carry out that service in a timely fashion for $7.77. They're committed to doing so. ACLA members are committed to doing so, but we worry profoundly about the impact of those reductions.
All right, I appreciate that. Mr. Ryan, appreciate you being here today. And you raised a couple of questions in your testimony, but I'm going to go to my set question first, and then we'll see if we have time to get to the others. My district is considered very rural by many metrics. I represent Southwest Virginia and Southside Virginia, Appalachian region of the Commonwealth. According to the competitive bidding process that CMS implements, CMS determined that a good portion of my district is non-rural. Can you briefly explain how CMS decides this designation? Because I'm looking at the map here of what's considered non-rural, and I can't figure it out.
Thank you, Mr. Chairman. A lot of people can't figure that out. Medicare used a set of zip codes, and in the zip codes, they chose what areas of the country were going to be competitively bid, the CB areas of the country, what areas of the country would be rural areas of the country, and then what areas of the country would be non-bid, non-rural areas. So your district probably has a lot of these non-bid, non-rural areas. Obviously, HR 2005 would help with that. The SOAR Act would help with that, because you get increased reimbursement for those product categories if that, in fact, comes into place. But that is a common question that's asked, and people are questioning CMS's methodology on that zip code application, and it is just one of the flaws of the program.
Well, and I'll have to check into that further, and I appreciate your answer, because I've got a couple of counties. Some of them I understand, but then I've got a couple of counties and a couple of communities that I just can't figure out how Duffield or Newcastle in Craig County, a county that has about 4,000 people and is owned by the National Forest Service, about half of it's owned by the National Forest Service, how that's not rural. I don't understand that, but c'est la vie. Can you, for the people back home, can you please explain what has already been done to help rural areas subject to competitive bidding?
Yes, we had worked with Congress in the past, and we've enacted the 75-25 blended rate, which I said was in effect essentially till the end of 2023. And we've also worked with Congress and worked with the administration. And in that rural area of America, which originally was being reimbursed at 110%, we've made it, well, it's not permanent, nothing with CMS is permanent, but we have a fix now that we get paid a 50-50 blended rate. Now, these percentages we talk about are essentially the adjusted amount or the bid amount and the unadjusted amount.